West syndrome and infantile spasm. Based on review by Pavone et al. 2020, prepared and edited by Dr. Hamza Alsayouf, since its first clinical description on his son by William James West, 1793, 1848, in 1841, and the definition of the classical triad of 1. Infantile spasms, 2. Hypsarrhythmia, and 3. Developmental arrest or regression as West syndrome, new and relevant advances have been recorded in this uncommon disorder. New approaches include terminology of clinical spasms. For example, infantile (IS) versus epileptic spasms (ES). Variety of clinical and electroencephalographic (EEG) features. For example, typical ictal phenomena without EEG abnormalities, burden of developmental delay, spectrum of associated genetic abnormalities, pathogenesis, treatment options, and related outcome and prognosis. Aside the classical manifestations, IS or ES may present with atypical electroclinical phenotypes. For example, subtle spasms, modified hypsarrhythmia, and may have their onset outside infancy. An increasing number of genes, proteins, and signaling pathways play crucial roles in the pathogenesis. This condition is currently regarded as a spectrum of disorders, the so-called infantile spasm syndrome, IOSS, in association with other causal factors, including structural, infectious, metabolic, syndromic, and immunologic events, all acting on a genetic predisposing background. Hormonal therapy and ketogenic diet are widely used also in combination with classical and recent pharmacological drugs. Biologically targeted and gene therapies are increasingly studied. The present narrative review searched in 7 electronic databases. Primary mesh terms, keywords, included West syndrome, infantile spasms, and infantile spasm syndrome, and were coupled to 25 secondary clinical, EEG therapeutic outcomes, and associated conditions terms, including Medline, Embas, Cochrane Central, Web of Sciences, PubMed, Scopus, and OMIM to highlight the past knowledge and more recent advances. An increasing and changeable number of terms on the disorder first reported by William James West, 1793, 1848, on his own son James Edwin, 1840-1860, in 1841, and subsequently labeled as West syndrome, WS, have been progressively proposed, first adopting the term infantile spasms, IS, in accordance with the most relevant clinical event, and later the term epileptic spasms, ES, since the disorder may have its onset outside infancy. The classical terms WS and IS are still the most quoted in the literature, and concordantly, the term ES has been incorporated within the umbrella definition of infantile spasms syndrome, ISS. As the different seizure types, the EEG and developmental features tend to occur all together and at the same time. The ISs belongs to the group of early epileptic encephalopathies, EEE, characterized by severe drug-resistant epileptic disorders with onset in early life, associated to persistent EEG abnormalities and cognitive defects. By definition, in this group of disorders, the seizures per se may contribute, above and beyond the causal effects, to the progression of cerebral dysfunction. The ictal phenotype is the result of a cellular molecular cascade of events, which in turn is responsible for the neurodevelopmental abnormalities. The ictal phenomenon, without associated EEG abnormalities, has been reported. In several reports, West syndrome, infantile spasms, epileptic spasms, and infantile spasm syndrome, and WS, IS, ES, and ISS, are still used interchangeably. In this report, we prefer to use the term IS to indicate the ictal phenomenon and the term ISSs to describe the spectrum of disorders associated to IS. Over the last years, new advances in all the relevant and less common aspects of this uncommon disorder have been achieved, including its nomenclature, etiology, associated genetic factors, variety of clinical features and complex phenotypes, and modalities of treatment and prognosis. The ISs is estimated to occur in about 0.249 cases 1,000 live births, with an overall prevalence of 1/10,000 children at the age of 10 years. The number of affected children by this condition is consistent over time, and no increase has been recorded in the most recent population-based and case series studies. Both genders are affected by a relatively small prevalence of males. Ideologic factors. ISS, one syndrome, one phenotype, for many different etiologies. The overall spectrum of the so-called ISS, as it occurs for other neurological disorders, including epileptic seizures and cognitive and behavioral developmental disabilities, is caused by different pathogenic events, some of which are still unknown, while others are well recognized: structural, infectious, metabolic, and immunologic defects and genetic abnormalities. 6.6. All these factors may act mostly as single causal events or in complex associations. Often, an obvious etiologic distinction is not strictly feasible, since different events may concur in causing the ISs. In about 35% of cases, the etiologic event is still unknown. The outcome in these cases is usually more favorable as compared with the group with recognizable etiologies. Euskaitis et al. 13 reported in 133 infants with ISs of unknown origin. Normal development in 15% versus clinically well-documented developmental delay in the remaining 85%. The causes of ISs may have their origin in the prenatal, perinatal, and postnatal period. The hypoxic ischemic encephalopathy is reported as one of the most common causes of ISs. In the study carried out by the United Kingdom Infantile Spasm Study, UKISS, in 127 out of 207 patients affected by ISS with proven etiological diagnosis, hypoxic ischemic encephalopathy was reported in 10%, followed by chromosomal abnormalities, complex malformation syndromes, and perinatal stroke, 8%, tuberous sclerosis, 7%, and paraventricular leukomalacia or hemorrhage, respectively, in 5%. Hypoxic ischemic encephalopathy, prenatal cerebral infections, and stroke may act causing permanent cerebral damage manifesting subsequently with IS. It must be noted that many of the etiologic events in the UKSS study are similar from a strict pathogenic viewpoint. For example, the molecular cellular events leading to the typical brain defects in tuberous sclerosis, which is regarded as a malformation of cortical development, are similar to the events occurring in some complex malformation syndromes or in chromosomal abnormalities with brain structural defects. That may occur as a cascade of involved genes, proteins, belongs to common intracellular signaling pathways. Most importantly, many recent studies highlight that vascular events of all types, that is hypoxic, ischemic, stroke, infections, metabolic and immunologic defects, may act on a genetic predisposing background. More recently, the results of a study carried by the National Infantile Spasms Consortium in North America on 161, 64.4%, out of 250 IS's patients in whom the etiologic cause was achieved, revealed that genetic factors were recognized in 14.4%, genetic structural in 10.0%, structural congenital in 10.8%, structural acquired in 22.4%, metabolic in 4.8%, and infectious in 2%. In this respect, according to the widest epidemiologic studies, genetic molecular involvement has been increasingly recorded in patients with ISs when using modern genetic technologies, that is, array, CGH, NGS, WS, and WGS, allowing the identification of an increasing number of genes or copy number variants, CNVs, involved in the direct expression of the ISs. The molecular cellular anomaly may act directly in generating by itself the neuronal brain structural phenotype underlying the ISs, or indirectly by causing a complex syndromic phenotype, that is, a recognizable malformation syndrome or an inborn error of metabolism, or by predisposing, at the cellular level, to a vascular or infectious event. Genetic causes may be involved in yielding the ISs through several mechanisms: chromosomal or large single gene abnormalities, or CNV, or a mixture of all of these factors. The role of genetics as an etiologic factor. As reported by Sheffer et al., the majority of genes involved in ISs show a phenotypic heterogeneity, as it occurs with other neurological disorders. A genetic predisposition to cause IS was advanced by Dulac et al. And by Heminke et al. On the basis of the observation that the chance of having ISs was increased in families in which other members were affected by epileptic seizures. A genetic predisposition in cases of ISs was also confirmed by reports of IS in twins. In this latter respect, Pavone et al. First described the occurrence of IS in a set of monozygotic twins who had their onset of spasms within a short interval of time, a few hours, one from the other. Similar findings were recorded by Coppola et al. In 3 independent sets of monozygotic twins. In each set of twins, the epileptic spasms appeared on the same day, within hours, one twin from the other. This phenomenon is difficult to explain. We could only hypothesize that a time-related, pre-programmed molecular cellular event may act triggering, in a given individual, the onset and the overall occurrence of spasms, somewhat similar to the programmed phenomena of apoptosis and cellular death occurring during life. A different, likely complementary explanation could be that environmental triggers affect ISS genetically predisposed monozygotic twins at the same time. Direct involvement of genes in the etiology of ISs was related to the detection of mutations of the Aristolase-related homeobox, ARX1, gene and the cyclin-dependent kinase-like 5 gene, CDKL5, both located in the human chromosome XP22 region, in patients affected by complex malformation phenotypes with ISES. These 2 genes are widely expressed in fetal brains, and their role in brain developmental has been firmly demonstrated. As reviewed by Pashy-Orkowski et al., mutations in other than X-linked genes, including PAFA1B1/LS1, DCX, and TUBA1A, are also frequently associated with ISS. These genes are expressed in GABAergic interneurons, and their mutations have been regarded as a direct cause of IS, secondary to neuronal cell disruption during embryogenesis. Other ISS-causing genes include STXBP1, KCNQ2, GRIN2B, and GRIN2A, and MAGI2. Further and more recent causative mutations of genes involved in the pathogenesis of ISS include the SPTCAN, FOXG1, and NSD1 genes, thus confirming the wide variety of involved genes causing ISS. A study of Boutrey-Kriza et al. On 73 patients with different types of ISs by means of array CGH testing and genomic sequencing revealed anomalies in CNVs in multiple genes in up to 15% of patients, including 3 patients who harbored specific point mutations in CDKL5 and STXBP1 genes. They also recorded ISS patients yielding microdeletions in the 2q24, 3, 5q14, 3, and 9p34 regions, respectively, and microduplications in the 2q24, 3, and XP28, 11.93 regions, according to the same study, the 16p12. 1 deletions recorded in their ISS series, which included intronic deletions of the NEDD, 4 gene, and intronic deletions of CALN1 gene, could be regarded as potential risk factors for ISS. Recent studies have expanded the spectrum of ISS-associated genes by including mutations in WDR45, KCNQ2R, 198Q, SLC1A4 variant, RARS2, UBA5, IRS2, HCDKL5, and Factor 1 genes. A study on a cohort of 56 Chinese families with ISs screened by means of WS revealed 17 novel ISs, candidate genes, ATP2A2, CD99LA2, CLCN6, CYFAP1, CYFIP2, GNB1, GPT2, HU1, KMT2D, MYO18A, NOS3, RYR1, RYR2, RYR3, TAF1, TECTA, and UBA. Most recently, ISS children harboring 5q31, 2q31, 3 microdeletions, a region embedding the pura-purine-rich element binding protein A gene, were reported by Shimojima et al. De novo mutations in the Pura gene are responsible for a neurodevelopmental disorder, the so-called Pura syndrome, characterized by severe intellectual disability, epilepsy, feeding difficulties, and neonatal hypotonia associated to respiratory and gastrointestinal problems, eye anomalies, endocrine defects, exaggerated startle responses, hypersomnolence, and hypothermia. These latter findings further demonstrate how wide and complex is the evolving spectrum of neurodevelopmental disorders, including typical and atypical, IS in their phenotypes. Additional causal factors. 1. Structural brain disorders. Structural brain abnormalities are well-known causes of IS and ISS. Lissencephaly, focal cortical dysplasia, polymicrogyria, hydranencephaly, and hemimegalencephaly are some examples of IS's underlying developmental brain anomalies. Specifically, the PAFA1B1/LS1 and DCX genes, which are related to classical lissencephaly, appear to be associated to ISS in about 80% of affected children. A de novo heterozygous mutation of KIF2. A gene has been reported in a child with lissencephaly, developmental delay, in IS. Recently, a child with IS and paraventricular nodular heterotopia was found to harbor an unbalanced chromosomal translocation 3p26, 210p15, 1 in A6q22, 31 duplication. A child with a novel homozygous nonsense mutation in the B3-GALN-T2 gene was reported with clinical features compatible with a diagnosis of Walker-Warburg syndrome, ISS, and sensorineural hearing loss. 2. Complex malformation syndromes. The Down, Pallister-Killian, and Williams-Burron syndromes have been often associated to ISS. In a study of 183 Down syndrome patients admitted to our institution in the 1990s, 15 complained of epileptic seizures, and among these 4 suffered from ISs. According to Tapp et al., the prevalence of epileptic seizures in patients affected by Down syndrome ranges from 1 to 13%. Among these, 32% present with ISS. Mosaicism for tetrasomy of chromosome 12p is the main cause of Pallister-Killian syndrome. Affected patients show skin pigmentation, bite and poral alopecia, rugged-looking face, epileptic seizures, and intellectual disability. Notably, these patients present late-onset epileptic spasms. Williams-Burron syndrome, WBS, is linked to a chromosomal microdeletion manifesting with characteristic facial features and heart problems associated with intellectual disability and happy and affable behavior. Marshall et al. Reported on a WBS patient with ISS harboring a large deletion on chromosome 7q11, 23q21, 11 embedding the MAGE-I2 gene. Anecdotal cases of ISE have been reported within the context of Schinzel-Guidon, Smith-Lemli-Opitz, Smith-Magenis, and Soto syndromes. Epileptic spasms have been also recorded in a male infant with PPP1-CB-associated Noonan-like syndrome. ISS-associated features are the presenting manifestations of 2 well-characterized syndromes, the PEHO and Aicardi syndromes. The PEHO syndrome is a rare and progressive encephalopathy presenting with edema, hypsarrhythmia, and optic atrophy with remarkable cerebellar atrophy due to granule neuron loss. Recently, a mutation in the ZNHIT3 gene has been identified as its primary cause. Aicardi syndrome is a neurodevelopmental syndrome affecting the female gender, corpus callosum agenesis, retinal lacunes, severe intellectual disability, and ISs with an EEG showing asymmetric hypsarrhythmia are the main abnormalities. Brain tumors, especially affecting the choroid plexus, have been also reported. 3. Inborn errors of metabolism. Phenylketonuria, PKU, is an inborn metabolic disorder caused by a mutation of the gene encoding for the enzyme phenylalanine hydroxylase, PAH, which converts the amino acid phenylalanine into tyrosine and other components. In the pre-screening era, the PKU incidence was as high as 1 in 5,000 newborns and was characterized by skin hypopigmentation, severe developmental delay, and seizures including ISs. In untreated patients, severe brain demyelination and abnormalities in gray matter are responsible for the severe cerebral involvement. A rare but more severe subtype of PKU is a disorder related to tetrahydrobiopterin, BH4 deficit, a coenzyme of PAH. In untreated patients, developmental delay and epileptic seizures of the ISS type are almost constantly reported. Early onset inborn errors of metabolism may present with ISs as their first manifestation. Al-Rifai et al. In a group of 80 children presenting with ISs, recorded a diagnosis of neurometabolic disorders in 10, 12.5%. Among these, 2 showed a Lee-like disorder. The others were affected by ethylmalonic aciduria, non-ketotic hyperglycemia, caused by the GCSH gene, hyperinsulinemic hypoglycemia, HHF17, short-chain acyl coenzyme A, dehydrogenase deficiency, caused by the AKDS gene, molybdenum cofactor deficiency, subtypes MOCS12, caused by the GPHN gene, primary carnitine deficiency, caused by the SLC22A5 gene, and neonatal hypoglycemia, secondary to hypopituitarism, subtype CPHD15. ISS may be also a clinical feature in children with glycine encephalopathy, caused by the GLDC and GCST genes. DEN, developmental delay, epilepsy, neonatal diabetes caused by the KCNJ11 gene, methylmalonic aciduria caused by the MUT gene, maple syrup urine disease caused by the BCKDHA, BCKDHB, DBT, and DLD genes, and propionic acidemia caused by the PCCA and PCCB genes. ISS have been also reported in children with neurodegenerative disorders, including globoid cell leukodystrophy, Crab disease, caused by the GALG gene, and Menkes disease, caused by the ATP7A gene. Rare disorders associated with ISs also include cerebrotendinous xanthomatosis, caused by the CYP27A1 gene, glucose transport 1 deficiency, caused by mutations in exon 9 of the SLC2A1 gene, disorders of glycosylation, caused by the ALG1, 6, 11 genes, subtypes CDG and CDG1X. Pyridoxine-dependent epilepsy, PDE, may present with various types of severe seizures, partial and generalized seizures, atonic and myoclonic seizures. Convulsive status epilepticus, an ISS mutation in ALDH7A1 gene, encoding the alpha-amino adipic semialdehyde, alpha-AASO dehydrogenase, and tiquidin, is a well-recognized cause of epileptic seizures, including ISs. As reported by von Karnebeek et al., PDE may manifest with atypical features with late onset and different response to the pyridoxine and metabolic disturbances like hypoglycemic episodes, lactic acidosis, and electrolyte anomalies. Neurotransmitter and neuroimaging abnormalities may precede the onset of ISs. We have followed an infant with ISs clinically, and EEG confirmed in whom treatment with large daily supplements of pyridoxine resulted in disappearance of the symptoms. 4. Neurocutaneous disorders, phocomatoses. ISS may be one of the earliest manifestations in some neurocutaneous disorders or phocomatoses. Within this context, affected children typically show non-causal associations of congenital skin and eye anomalies in central and peripheral nervous system structural abnormalities and/or tumors, and neurological manifestations often associated to systemic involvement. For example, the heart and vessels, lung, kidney, and bone. A tuberous sclerosis complex, TSC. TSC is the most common example of a neurocutaneous disorder typically associated to ISS. TSC-affected children often, up to 90% of cases, present with different epileptic seizure types. Mutations in either the TSC1 or TSC2 genes through the Hamerton-Tuberin complex and mTOR pathway cause neuronal interneuronal disruption, which in turn leads to a malformation of brain cortical migration and layering, which is reflected by the development of cortical tubers, white matter anomalies, subependymal nodules, and related subependymal giant cell astrocytoma, and brain cysts. These brain structural abnormalities form the basis of susceptibility to manifest epileptic seizures and of the overall neurodevelopmental, behavioral, and cognitive defects. In a study on a population of 81 TSC children with a median age of 10 years, epileptic seizures occurred in 91%, including 32% with a history of ISs. Several studies documented an important decrease in frequency and severity versus cessation of seizures in TSC patients with drug-resistant epilepsy, including individuals with a past history of ISS, treated with focal cortical tuber resection. New treatments with single and/or combined mTOR inhibitors have been proposed in patients with TSC and drug-resistant epilepsy, including ISS, but criticism was raised by the remarkable side effects related to their use and by the relatively poor efficacy over time. B. Neurofibromatosis type 1, NF1. Patients with NF1 show a genetic predisposition to the development of benign, and less frequently malignant, central and/or peripheral nervous system and systemic tumors, which are related to the effect of loss of neurofibromin, the NF1 gene protein product. In a cohort of 630 NF1 patients, 37, 5.87%, suffered from epileptic seizures. Among these, the most common seizures types were partial and primary generalized, with only 2 children presenting with ISs. In a large multi-center hospital-based study and systematic review of the literature, the NF1 children presenting with IS represented only 1.5% of the NF1 population, most having a more favorable outcome. Seizures, epilepsy, and infantile spasms within the context of NF1 have been related to disruption in the RUS/NF1-related MEK/MAPK/ERK signaling pathway. C. Sturge-Weber syndrome. Capillary vascular malformations of the embryonic facial vasculature, the leptomeninges, including underlying neuronal disarrays, and the choroidal eye layer are the main features of SWOS. This complex vascular developmental disruption syndrome is caused by somatic mutations in the GNAC gene, a nuclear structural gene responsible for vessels and neuronal development. Epileptic seizures, as well as cognitive and behavioral abnormalities, are the most frequent clinical manifestations of the disease and are reported to occur in up to 77% of patients with unilateral and 92% with bilateral brain involvement. The epileptic seizures are mainly of the partial but also tonic-clonic generalized types. IESS have been sporadically recorded. Depigmentary mosaicism of the hypomelanosis of Ito type. Seizures in epilepsy, occasionally including ISs, can be recorded in children and adults with skin pigmentary, usually of the hypopigmented type, whorls and streaks following the lines of Blaschko. That is a system of lines in the skin reflecting the arrangement and migration patterns of pigmentary cells in the human embryo and later in postnatal life. Affected individuals can present also associated extracutaneous abnormalities, mostly affecting the eye, musculoskeletal, and nervous systems. This latter complex malformation phenotype is currently known as hypomelanosis of Ito, a condition which reflects somatic mosaicism for some yet unknown pigmentary genes. Epilepsy and the occurrences of ISs within the context of hypomelanosis of Ito is likely due to the minor mosaic migration disordering manifesting as white matter disarray, typically associated to the more severe complex neurological phenotype. Role of immunity. Recent studies have hypothesized the possible role of immunologic events as triggering factors of ISs. This is related to the observation that some genes involved in the pathogenesis of ISs play also crucial roles in a variety of inflammatory cascades and signaling pathways. Lemke et al. Reported mutations in the GRIN2B gene, which encodes the NR2B subunity of the N-methyl aspartate NMDA receptor. In 2 children with ISS, NMDA receptors are involved in a number of neurological disorders. Notably, elevated titers of antibodies against the voltage-gated potassium channel complex proteins, VGKC, that is 201 pMOL, normal values equal sign 100, were reported in an infant aged 4 months with ISS